So it is with great pleasure now that I would like to introduce our guest speaker today, Dr. Sharon Lewis. Dr. Lewis earned a degree in biology at the University of Miami and then went on to earn her medical degree at the University of Miami Miller School of Medicine before completing her residency and neuromuscular fellowship at the University of Pennsylvania. Dr. Lewis is currently an associate professor of neurology at the University of Pennsylvania. And throughout her career, she has pursued a passion for mentoring and teaching, particularly students who are underrepresented in medicine. And with knowledge that the pipelines for students that are underrepresented in pursuing STEM-based fields and healthcare fields, she has become a leader in promoting mentorship and students through into these fields through her work at the Penn Educational Pipeline Program. She joined this as a resident and eventually became the program director and has created, with the help of the EPP, the Educational Pipeline Program, a multi-tiered mentorship and educational opportunity that teaches healthcare concepts and self-efficacy to local students in West Philadelphia, local high school students. And now she is working as an assistant dean for diversity recruitment in the program for diversity and inclusion at the Perelman School of Medicine at the University of Pennsylvania. And she's an advisor for several healthcare pipelines, which impacts both high school students, students from high school all the way to undergraduate to medical school as well. As an assistant dean, she is the mentor to all the underrepresented students that come in through the medical school in order to help them navigate their journey through medical school. And she liaisons with the Office of Admissions, student leaders within the medical school in order to create innovative strategies to retain students and recruit a more diverse class into the medical school. She also collaborates with key stakeholders within the medical school leadership to ensure a very inclusive environment that creates a sense of community amongst all students, regardless of their backgrounds. To these endeavors, Dr. Lewis has been recognized with several awards for clinical excellence, as well as teaching and mentorship. She's also an alumnus of the AAN's Diversity Leadership Program and volunteers in multiple roles at the Academy. Today, she will be talking to us about healthcare inequities in neurology. Welcome, Dr. Lewis, and thank you for joining us today.
Thank you, Dr. Torres. It was a very nice introduction. I'm blushing now. So thank you all for coming today. Particularly it's 4 o'clock on a Friday, my time. So I really appreciate those who came out, to hear me talk. So I am going to share my screen. So thank you to Dr. Torres, who gave me a wonderful introduction. So I'm an associate professor of neurology at the University of Pennsylvania. All right. So today I'm going to talk about healthcare inequities in neurology. And basically in this talk, I'm going to discuss the scope of the problem. It's not meant to be exhaustive, but to highlight a few diseases that demonstrate disparities in the outcomes for underrepresented minorities or populations. And I want to discuss the factors that contribute to creating gaps in care. And lastly, I will show some suggestions for tackling this problem. So I want you to meet Alana Brown. She is a 42-year-old woman with a prior history of hypertension and diabetes who had a small minor stroke 2 years ago. This stroke left her with a mild gait abnormality due to some spasticity in her right leg. What are the chances that Alana will be referred to a neurologist as an African-American woman living in the United States? So one study by Sadi et al. Showed that Black participants were nearly 30% less likely to see an outpatient relative to their white counterparts, even after adjustment for demographics, insurance, and health status differences. What if Alana was a 30-year-old Latinx female with epilepsy? What is the likelihood that she will be referred to a neurologist? So she's 40% less likely to be referred to a neurologist. She's likely to be cared for in the emergency department as opposed to an outpatient neurologist. She's likely to have more hospital stays and to have higher per capita inpatient expenditures than her white counterparts. A neurologist's involvement in the care of people living with neurologic disease reduces adverse events and acute care hospitalizations. And we know that looking at neurologic disease, that it's on the rise with a steady increase in the number of people who are going to need neurologic care, and as our population becomes more and more diverse, that also has the potential of increasing more diversity gaps within our healthcare system. So the CDC's definition of healthcare disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. When discussing healthcare disparities, there's often a focus on racial and ethnic healthcare disparities. However, it is important to note that there are several other groups that suffer from these disparities. These include low socioeconomic status, uninsured and underinsured, non-English speakers, amongst others. And when individuals have intersectionality, meaning that they share more than one of these identities, these disparities are likely to be further amplified. And this is something that's important to note as we take care of our patients, to really take note at how they identify and how many of these characteristics identify the patient within the patient. So I want to define these seemingly interchangeable terms, and I can't promise you that I won't interchange them even in this talk. So when you look at the research on healthcare disparities and inequities, these terms are sort of used, interchangeably. But I want to sort of give some definitions so that we're all on the same page. So when we talk about, equality, we're talking about this sameness or parity. When we're talking about equity, we're talking about social justice or fairness. And when we're talking about disparities, we mean inequality. So in North America, most healthcare disparities and inequalities are inequities, meaning that it's due to social justice and social determinants of health, which we'll talk about. And so they are avoidable and thus unfair or unjust. So the main driver of healthcare inequities are the social determinants of health, as I mentioned. These are the conditions in which people live, learn, work, and play that affect a wide range of healthcare risks and outcomes. We know that poverty limits access to healthy foods and safe neighborhoods, and that more education is a predictor of better health. We also know that differences in healthcare are striking in communities with poor social determinants of health, such as unstable housing, low income, unsafe neighborhoods, and substandard education. All these factors contribute and cause structural forces which perpetuate the inequities in healthcare outcomes. The social ecological model that you see here demonstrates this interaction between the individual and society to determine the social determinants of health. And this is going to become important. A lot of research is really being focused in this area as we really think about how do we really address these social determinants of health, because they really do create structural barriers for many patients. So I'm going to go through some disease states, really highlighting where some of these inequities are clear. So stroke is the leading cause of disability and the third most common cause of death in the US. The AHA published a study showing that there are differences in outcomes depending on your ethnicity, and African American, Native American, and Hispanic patients had worse outcomes. They had higher incidence and prevalence of stroke. Strokes occurred at a younger age, between the ages of 45 to 64. And the stroke mortality is 3 times that of whites. The recurrent stroke is higher for African Americans and Hispanics, highest in African Americans. There's higher impairment or morbidity associated with being from an underrepresented background. And they're less likely to receive medications for primary and secondary prevention. TPA is also less likely to be given to these populations. And there's a whole host of factors. There's a lot of research in this domain to think about why this occurs. Some of those factors that come into play are physician bias, cultural barriers that come into play here. What about migraine? So this is near and dear to my heart. I see a fair number of migraine patients. Migraine represents the 6th highest cause of disability worldwide, and it's the 5th leading cause for women. It's the 5th leading cause of visits to the ER. Your risk for developing migraine is directly linked to the social determinants of health, which include but are not limited to housing instability, transportation, food insecurity. This is reported to be 2 times as likely in patients suffering from migraines. Social support, language discordance, and lack of insurance. Studies show that if you're living in a household with income less than $90,000 per year, that reduces the risk of migraine by almost 50%. And if you're insured, you're 2 times as likely to receive a correct migraine diagnosis. And if you're underinsured, you're less likely to receive migraine-specific abortive management. So these social determinants of health really do determine even your incidence of pain, which obviously you could think about the cascading factors. If you have a migraine, loss of work, potentially loss of job, which then just kind of further, complicates and makes you more in a more disadvantaged background. What about epilepsy? So it has been shown that there's higher incidence in underrepresented populations of epilepsy, 1 to 3 to 2.2 times greater for white males. For non-white males compared to white males, and 1.4 to 1.7 times greater for non-white compared to white females. And African Americans and Hispanic patients are less likely to undergo surgical treatment, particularly for those who are refractory to medications. They're more likely to be treated in the emergency room, as I mentioned, for seizures, less likely to receive an anti-epileptic medication, and less likely to receive specialized care. And you have to ask yourself, what are the reasons? What are these driving factors that are coming? And as I go through the talk, it'll be clear and evident that there's multiple factors that are at play here. So I would be amiss to not discuss how COVID amplified the already existing healthcare inequities in underrepresented populations. Individuals from low income and racial and ethnic communities are overrepresented in the essential workforce, more likely to have pre-existing conditions like hypertension or diabetes, and are much more likely to live in a multi-generational household or densely clustered housing. They're less likely to have access to sufficient healthcare and protective equipment, let alone sufficient sick leave or resources to quarantine safely. And so really the COVID pandemic really did see these gaps, really highlighted these gaps in healthcare outcomes for underrepresented populations. So looking at the U.S., I want to highlight really disparities in outcomes for underrepresented populations. So in Illinois, African Americans represented 43% of the people who died of COVID, yet they only make up 15% of the population. In Michigan, African Americans were 40% of the deaths, but only 14% of the population. Louisiana, 70% of the deaths were Black, and they only represent 33% of the population. In Utah, Latinx individuals were infected and hospitalized at 3 times the rate of non-Latinx individuals. 29% of patients tested positive for COVID, but they only represented 14% of the population. And in New Jersey, close to me, Latinx individuals represented 30% of the COVID of infected patients with COVID-19, yet only 19% of the population. So you can, again, this highlights the disparities of infection rates in underrepresented populations. So in the US, the same risk factors for stroke, hypertension, obesity, diabetes are more prevalent in Black, Latinx, and Native communities due to historic and ongoing health inequities. And these same risk factors lead to an increased likelihood of being infected and having increased severity of disease. Social distances and stay-at-home order were easier for people with privilege. There were also disparities in access to televideo with older patients, and one study showed that older patients were more likely to just have audio availability. Commercial insurance was less likely to have commercial insurance and more likely to be on Medicaid. And you would have potentially an audio visit, but not the access to the televideo, which you saw we really utilized during the pandemic. And one retrospective study, which examined telestroke care in 38 hospitals, demonstrated an overall decrease in the number of stroke consults, with the largest decrease for Black patients. This study demonstrated limited access to ER care for Black and Latinx patients. And this is really concerning because studies do show that underrepresented populations tended to use the ER more than they use the outpatient neurologist, thus, again, highlighting that lack of access really did affect outcomes for these patients. So why do health inequities exist? So one study by Nathan et al. Published a paper looking at some of the factors that contribute to surgical disparities that I highlighted. Why are underrepresented populations less likely to undergo surgical management of refractory epilepsy? And he looked at these factors as potential, barriers to getting surgery. So, and the other thing that he did in this study was to look at how some of these factors differentially affect the African-American population and the Latinx population, but all these factors played a role. So fear of treatment, and this is based on historical, distrust that's established with the medical system, access to care. So we talked about that, and I'll highlight that further on in my talk. Communication barriers, so thinking about language concordance and how that plays a role. Education, so how are we communicating why someone would need surgery? Are we getting patients up to speed with healthcare literacy? And are we educating patients in the same way? And is that correct for depending on the population that we're dealing with? And then again, coming back to fear of treatment, is there established trust between patients and physicians? And what is their social support? If they are to undergo surgery, who's there that's going to be able to help, if mom or dad has to go to work and has to take care of someone, or if the person has to work, what's the social support that's in place? And all of these factors with the mnemonic facets really play a role in I think, this was in the epilepsy surgical model, but really you can look at it in many different disease states that these factors likely play a role. So this study really looked at the geographic location of level 4 epilepsy centers. And these are going to be needed for patients who have refractory epilepsy or very complicated epilepsy, would want to go to a level 4 center. So these maps looked at the level 4 epilepsy centers, which are the white dots on the maps, the prevalence of epilepsy, and the area deprivation index score, the ADI score, which was used as a measure of socioeconomic disadvantage, with the higher score indicating more disadvantage. This study found that 8 states were found to have no level 4 epilepsy centers. And of the 8 states with no level 4 centers, Alaska, Montana, North Dakota, and South Dakota had large percentages of American Indian and Alaskan Native populations. This study found an inverse relationship between the ADI score and the presence of a level 4 epilepsy center, meaning that the higher the score, and therefore the more disadvantaged populations, were less likely to live near a level 4 center. So again, highlighting that geographic area and your socioeconomic status or social determinants of health really do determine what kind of level of care that you get, and adversely affects your outcomes. What about communication barriers? So one study showed that Spanish speakers had significantly lower number of anti-epileptic drugs prescribed to them compared to US-born patients. Another study showed that even with language concordance, African Americans had shorter visits with white physicians, and physician verbal dominance was significantly higher, even with both African American and white doctors. So even when there was race concordance, there was this sort of paternalistic way in which communication happened, and that can create a distrust, or can create a dynamic in which it's not a shared decision making, which I think medicine is moving more towards really getting the patient's views, values in place, and before we recommend treatments for patients. And so these different cultural beliefs, the fact that 20% of Americans speak a language other than English, really does affect outcomes. And so it's important to really address that and to get translators involved when needed. So we talked about verbal communication. This study was really interesting to me because it talked about the nonverbal communication that happens at bedside. And this study was specifically looking at patients that were admitted to the ICU. And these were really end of life discussions. So a very emotionally distraught time in these families and these patients' lives. And what they found, and I think it's clearly demonstrated in these studies, was actually there was less positive interaction when you were from an underrepresented background. There were more, they had a video on these patients and they looked at things like open body language, percent time interacting with the patient, percent time non-diagnostically touching the patient, and the distance from the patient. So if you look at this, at these pictures, so, with the African-American patient on the right, you see the doctor is very far away from the bed. He has sort of closed body language with the chart sort of being clutched in front of his face. The family member is very close. You would presume, I know there's a box over the provider's face, but you would presume that he is probably looking at the patient while he's talking. And so what this study also found was that there was no difference in the verbal communication. It seemed that the providers were counseling the patients in a very similar way. However, there were these nonverbal communication cues that weren't happening that really do promote poor interactions with the physician and the family and the patient. It does impact patient rapport, trust, and satisfaction. And the scores were significantly lower for Black and for Black patients over white patients. And this is something that I think we all need to be aware of, because this is likely rooted in an implicit bias. I don't think this was a conscious decision. I mean, obviously I wasn't involved in all of these cases, but I'd like to think that this was not a conscious effort to not be close to the patient. And so looking at trust, there's a long history of mistrust in the medical field due to the mistreatment in medical care and research of underrepresented populations, and potentially the relationship with the community. This study by Ree et al. Demonstrated that perceived racism led to delays or foregone care. And these factors do intersect with each other, with poor doctor communication really mediating this delay. So the way that we talk to patients, the way that they really perceive our verbal and nonverbal communication has a huge impact, and also the trust relationship. And I know when I'm seeing my patients, a lot of the advice that I'm telling them really depends on that relationship that I have with the patient. And I'm constantly gauging that relationship to to see what they're willing to do, if they're going to follow my recommendation, what's likelihood that they'll adhere to what I'm asking for. If trust is eroded or there's no trust, with a patient interaction, it's very unlikely that you're going to let them, that you're going to get them to do something like give a monthly injectable for migraine, when they're really maybe hesitant or nervous about giving themselves an injectable when they've been on pills the whole time. So it really does erode your ability to be a good physician if you don't have that trust established. So I want to bring us back to the social ecologic model, which demonstrates the interaction between the individual and society as the main driving force for healthcare inequities, and really the social determinants of health. The U.S. Department of Health and Human Services Healthy People 2030 have recommendations that outline 5 primary domains of the social determinants of health. These include healthcare access and quality, education access and quality, social and community context, and economic stability and neighborhood and built environment. These conditions create social hierarchies that determine an individual's exposure and vulnerability to health conditions. These social hierarchies are created and sustained through structural determinants of health, which are political and social, and define individual positions in power and access to resources. So really, it's the interplay of all of these factors that really determine what the outcome is going to be for a patient. And these are all, I'll talk about this later, these are all potential places for intervention as well. So what are, what about implicit bias? Implicit bias tends to be more insidious, and we are more apt to resort to these biases when we're under pressure and have to think quickly. These create some of the disparities that we see in healthcare. The conditions such as giving TPA or under the pressure of a fast-paced outpatient clinic in which you're trying to see many patients under time constraints can create implicit bias. And this can be very dangerous because a lot of times patients and providers are not very aware that they're maybe differentially treating a social group that's, that might be different than them, or even the same as them, right? We all have some type of bias, and it can impact our decision-making. Explicit bias is obviously, providers or, are aware of that. I think what's the more insidious bias is really those implicit biases, and it can impact trust, which we spoke about, and it can really erode the patient encounter. And also as educators, it's really important to note that these biases can even be amplified as we pass down our fund of knowledge to trainees. So we want to make sure, again, how we're role modeling taking care of patients, from underrepresented backgrounds or from disadvantaged backgrounds, that we're not promoting or amplifying our own personal views about how these patients should be treated. So what are some solutions? And this is, is a challenging task about, how are we going to address this? I do think that with, we were aware of healthcare inequities. The COVID pandemic definitely amplified our awareness and really brought to light how much it can impact, people's lives. And so I'm going to really come back to that model, thinking about the social ecologic model, and really think about, talk about how when these interventions really do need to be multi-directional, you have to really tackle all of these domains that affect the social determinants of health. And that's really the key to addressing healthcare inequities. And studies show that when you're trying to change outcomes in populations, a lot of focus has been on the individual, and different strategies from that standpoint, but really you do need to address all these factors. And I just wanted to highlight that Rosendale did publish a recent report in 2022, really highlighting how these factors play a role. And this graph is from that paper. It's a great paper, really expanding how these domains affect stroke outcomes at every level. So, I'm actually, the next few slides are going to be really addressing that model through different interventions. So on the individual level, you want to really address implicit bias, that process of unconscious societal attitudes affecting our individual understanding, actions, and decisions, and kind of leading us to making assumptions about a group. And as I mentioned, it really is the perfect storm when you're under time constraints, at those implicit biases really coming out more. And there is this, I don't know if you guys have had a chance to do the implicit association test, but it's a way to sort of test your own biases. It's something we all have to be aware of, and we have to constantly have it at the forefront and kind of checking how we're treating patients. One study it's a pediatric study using the Chalice algorithm, which really is determining when a child with a head injury should get radiographic imaging, shows that when you implement this algorithm, you do reduce the impact of implicit bias. And so that's, thinking about how we can maybe do care in an algorithmic fashion. Obviously, taking the individual in mind might help to mitigate some of the disparities that patients experience. It does require this constant self-reflection, and other individual factors to consider are really trying to identify and intercede when you see a patient with a social determinant of something that's affecting a social determinant of health, and really being an advocate at multiple levels, the institutional level, community level, and really thinking about how you can even change at policies. The other thing is really thinking about healthcare literacy. And at an interpersonal level, enhancing healthcare literacy, promoting shared decision-making. We earlier talked about how underrepresented individuals are more likely to have this paternalistic style with medical decision-making. And you really want to start getting patients, really having a discussion with patients so they really feel that they're part of that discussion. And it's a way, again, to establish trust. So what about institutional factors? So really, studies have shown that diversity enhances the educational environment of everyone involved. It enhances research outcomes. And so it's very important to have diversity within our medical schools, within our physician workforce. And studies do show that race concordance can result in longer visits and increased patient satisfaction, and language concordance as the patients are more likely to adhere to treatment. But really, I think the main goal here is really that, by having diverse perspectives, we all become more culturally competent. Providers were able to do better care of our patients because we've had this diversity of experiences with a diverse population within the physician workforce. So near and dear to my heart, as Dr. Torres mentioned, is that I run a high school mentoring program. And one of this was really born out of the AAMC's initiative to try to get more underrepresented individuals within medicine. And when you look at the STEM pipeline, you see that there is a huge drop off, really from ninth grade into basically it's a 50% drop off, basically through ninth grade throughout high school, essentially. And so you really need to intervene early in underrepresented patients, students, because you want to have these students develop the self-efficacy. They're really the thought that they can do this work and that they can do STEM and they can think about healthcare and that they belong in this space. And honestly, you could even start earlier than that. It's never too late to kind of teach students from underrepresented backgrounds that they really do have, that they're an asset to healthcare, as opposed to, sort of being, coming from, a place of a deficit. They really, underrepresented individuals really are an asset to healthcare. And so, past studies have documented that middle school and high school students tend to lose interest in science really early on. And it's those lack of mentors from within the field that contribute to that. And so this critical phase really does happen very early. So what about neurology? So basically, when you look at neurology, underrepresented individuals represent about 5% of the neurologists come from underrepresented groups. And so, just wanted to, since this is, from the AEN, we really do need to look at what we can do as neurologists to try to increase the diversity within our group. And this is, many factors come to play here. And I will say, because I sit on several committees at the AEN, that there's definitely several efforts to really think about building the pipeline and how we get students involved at several levels, from high school, medical student, to think about neurology as a potential career choice. We do know that several undergrads really are looking at neuroscience as their undergraduate major, and we're losing those students as they enter medical school. And so what are the things that we can do to try to capture the interest and really show them how, completely biased, how cool neurology really is. And when you compare the percentage of neurologists to the US population, which is about 30%, it's not representative of the US population. And so other institutional efforts that we can think about are identifying resources for patients to really help them advocate for themselves, tackling communication. So we talked about those communication barriers, the verbal, the nonverbal, and then just, not having language concordance. And so really thinking about providing written and visual communication, making sure they're translator interpreter services, and that information is disseminated in multiple languages, and really checking again our bias and our nonverbal communication with patients. And so one really important area that we need to address is thinking about research. Really, if we want policy change, we have to really tackle several domains to think about what the best practices are for addressing social determinants of health and therefore addressing healthcare inequities. So we want to, from a policy change, we want to fund research that develops these best practices. We want to be able to detect these inequities. We want to then examine the driving forces that create these disparities, and then test interventions within the clinical population in order to break down these structural barriers. It is really important to engage the community in these efforts to build trust and rapport, and also to get buy-in It is also important for the study design to ensure that it's scalable and acceptable to the patients that that the study is targeting. So we really want to look at, there's community participatory research, and there's also community advocates that we need to engage within our research protocols to make sure, again, that things are in line with what is going to be acceptable to the community, and also to build that trust before, coming in to make a change, and for them to understand with that buy-in, you'll be able to get a better result. And then the other thing that we need to think about is reimbursement. Really social determinant variables can be incorporated into value-based reimbursement algorithms. We want to focus on preventative medicine as opposed to reactive medicine. So if we are able to reimburse services that address social determinants of health, and then also really commemorate or honor providers who are really addressing this, really showing us how to do this well. I think it's important to really think about doing that. And then thinking about health promotion policy enables people to have increased control over their health and improve it. It represents any activity destined to help people to change their lifestyle and move towards a state of optimal health. It does demand a coordinated action by government, health sector, other social and economic sectors, non-government and volunteer organizations, local authorities, industry, and media. And so the creation of health equity is a core tenet of public health. Advancing health equity requires the identification and amelioration of patterns of systemic disadvantage and elimination of healthcare disparities. So in order to really, promote health, we have to look at all those factors. And again, there's an intersection amongst all of them. So once you move one lever, you have to make sure that you're really addressing the other ones, really from a multi-directional approach. And so I want to return to Alana. And I think it's important to give these faceless, nameless reported numbers a name, right? When we talk about increased mortality and increased morbidity, 30%, 40%, these inequities represent millions of Alanas facing increased morbidity and mortality due to structural forces that maintain the status quo and create huge gaps in healthcare outcomes. So Alana is suffering from increased morbidity and mortality because of the compounding risk of an early death due to social determinants of health. And we as healthcare providers have a critical role in addressing these inequities and closing the gap. It truly is a life and death situation. So I want to thank you for your time and just remind you of those, those terms, and really thinking about, I am charging you guys to really think about how you can really be part of the solution. It's going to take all of us stacking hands and really thinking about how to address this at an individual level, and then, at a community level, and then at a policy level. So I want to say thank you for your attention, and thank you for being here.
Thank you, Dr. Lewis, for that amazing talk. It's always great to hear you give talks like this. It looks like Samira has a question for you. Samira, do you want to go ahead and do you want me to read the question for your question, or would you like to ask the question for Dr. Lewis? I'm not hearing anything. So she said, she's an international medical graduate and has applied to residency in the US. She said, thanks for addressing that issue. And she said, I have noticed that there's a lack of education, lack of knowledge about brain diseases and its long-term impacts on patients with color. What can we do to educate these underserved populations? Is there any group who works on this for now?
Yeah, no, that's a great question. So thank you for that. I mean, I do think that that, as I mentioned, there's a lot more awareness in this space. And I do think that we need to try to educate our patients that from underrepresented backgrounds. And I do think it's, yes, as neurologists, we want to do that, but it has to come from the primary care. It has to come from all sectors of the healthcare field. All I can say is that I do see like a change at many university and academic centers, and trying to reach out to the community and educate the community. I'll say, one of the efforts that we're doing at Penn is actually we will do a radio broadcast that primarily reaches an African-American audience. And so we're trying to reach the population through through means that we think that they would listen to. So I think it's important. I think you can be an advocate. I think that, sometimes as a student, you kind of wonder, like, what's my role, and, what voice do I have? But you actually have a major role. And I think I remember being a medical student and even just like seeing an underrepresented patient, just me being in the room was really exciting for them. So even your presence alone, you're really inspiring the younger generation, you're inspiring your patients. But I do think that there could be a larger scale effort and needs to probably come from academic centers, as well as community centers, right? It could be from all of us, and it's going to take, a widespread effort. So, I don't know if you could look at your institution where you are. I do feel like a lot of institutions are doing that. I know AAN is doing it. So if you're not getting it at your local, where you are locally, I think that the AAN is another landing space for you. So anyway.
There's an additional question. What are your activities regarding educational curriculum of medical students and residents / fellows?
Me specifically, or?
Sounds like it.
Okay. So my activities, particularly, what we're trying to do at my experiences at Penn. So I was trying to actually incorporate the healthcare disparities within the residency. And I do some of that, as well as my colleagues that are also very involved in healthcare disparities and residents. So they've really looked at that as an initiative within Penn. For the medical students, I primarily work with them in a mentorship level. So I think about how our underrepresented students might experience medical school differently and what potential barriers or changes that they have within their day-to-day just kind of medical school. So I'm there as a support and mentor for them. And so those are some of the activities that I do in the pipeline program. I'm obviously targeting high school students. So I really try to have an interactive, it's an after school program. So we try to make it as interactive as possible for the, geared towards high school students, where we teach them about neurologic diseases that disproportionately affect their community. So we think about stroke risk factors. We think about diabetes and how that may, be a vascular risk factor that impacts our patients. So, I would say me personally at multiple levels, I try to really support the underrepresented population that I work with from a student perspective. And I really think the things that we strive to do are really to try to highlight. One of the things that we wanted were that every professor that gave a lecture to our residents, that they incorporated an inequity within their lecture series. And we thought that education would be bidirectional, because I don't think that always happens. At least, when I was a resident at Penn, that rarely happened, when I was there. So I think it's something that we're more aware of and we're trying to incorporate into the education of residents, because I think the residents and medical school students are really going to carry the torch forward as well.
Someone said, Dr. Lewis, your presentation was compelling. If it was up to you to advise or establish equitable healthcare policies, can you share what you believe are the top 2 or 3 recommendations you would advise?
Yeah, so good question. So I think that if it were up to me, I do think that education of our patient population. So really healthcare literacy and thinking about like that 30 to 40% of, 30% of African Americans that are not coming to us as, and 40% of Latinx individuals who are not coming to us as neurologists, that would really do better. I think that one of the things is trying to get educational initiatives out to the patients so that they understand like what a neurologist even does. I don't know. I've encountered where, patients kind of think I'm a psychiatrist, or they think that I do surgery, say, oh, great, you diagnosed my lumbar stenosis. Now I'm going to go to you in the OR, right? So like just educating, our patients, I think is really important. And then I think, one of the big issues is, I think one of the issues that would have the highest impact is really reimbursement. Medicine is a business. And so if we really change policy, which allowed for reimbursement for addressing social determinants of health, I would say those are probably the 2 biggest factors, but, they all do need to be addressed.
Another question says, can you offer any suggestions for physicians looking to improve their ability to address neuro concerns stemming from multiple / intersectional social environmental inequities? Any resources, groups to join?
Yeah, so I will say, and I know I'm giving an AN talk, but I am going to plug the AEN. So they do have a free webinar as well, or a few like sort of virtual modules, which really, one, it's self-education to really think about these neurodisparities and how to address them. So I would highly recommend the modules. They're meant to sort of be done sort of in bite-sized pieces and then really think about them as a way to kind of think of like how you can be anti-racist as an organization. And so I think that's one of the resources that is free. And I think you should definitely take that. I'm going to plug that. And then as far as, I do think it depending on where you are, a lot of these things are regional. So I think, finding out at your university, do you have like a vice chair of diversity group and see kind of what they're doing. I would try to get involved kind of regionally from that standpoint, or even if you have a local neurology society, I think that's another way to get involved regionally. But if that's not a landing space, I think the AN has a list of resources. It's, going on the website and really looking at that. But if I had to say one high impact thing, I think it would be to do those modules on being kind of those modules on anti-racism.
As a follow-up to that, Diana said only 5% of underrepresented in academia is very eye-opening. What is the AAN doing to promote increased representation in academia? Yeah,
so yeah, I mean, I promise you that I'm getting no money from the AAN, but I will say that they're doing a lot. Dr. Torres did mention that I did the diversity leadership program, and I did that in 2019. I think that was transformative. So if you have a chance to do one of the leadership programs, I would highly, highly recommend it. I didn't know I needed it until I did it. I just kind of was at the stage in my career where I was looking for my next step. And so I think that was really, really transformative for me. And then through that, I've been able to have some more leadership roles within the AN at a national level. I've also taken on local levels, of leadership. So I think that is a really important resource that the AN provides. I also think that if you see the AN, I've been with the AN for a while. When you look at the lecture series, what the AN annual meeting looks like, but even I would say even like the fall, there is an emphasis on underrepresented individuals and healthcare disparities. There's the creation that Dr. Torres is on, but like the Ideas Committee, which really looks at a disparity and equity. There's also, it was before I even started for the diversity leadership program, there is a sort of that Ideas Committee is across all of the committees. So really all of the committees are supposed to be looking at a diversity lens to whatever initiatives they're kind of pushing forward. And so it's like sort of cross-cutting across a lot of the committees at the AAN. So I mean, I would, you're here at this talk, I would highly encourage you to look into because I think the reason is there's a place to plug into because there's never enough people kind of working on this initiative. So if you're interested in this space, there's a place for you. And I'm sorry, Wendy and Leah, but I'm putting it out there. There's a place for you at the AN, really think about how you can get involved because there are multiple ways to plug in.
The person said, great talk, Dr. Lewis. With the current political environment and polarizing rhetoric, what are the techniques/strategies that you have worked for to gain allies? In addition, there appears to be resentment from many historically underrepresented groups with affirmative action like interventions. Would socioeconomic status help mitigate this instead of purely race/ethnic lines, i.e. for poor rural groups or Asian groups that come from non-affluent group families like the Philippines or groups like the Philippines?
Yeah, so good question, a big question, a complicated question, but I think it's a good one. I mean, I think that one of the things that is that I've experienced and I think is something that's known is that a lot of underrepresented individuals end up taxed, right? They get this diversity tax of like, well, this is important to you, and it is. I'm passionate about this work, but there is, I'm still and I'm in an academic track. There's other things I need to do, and so you get stretched, right? And you feel obligated because of course I do want to reach back and help the generation that's coming up, underneath me to better, but then, to kind of, help them, support them along the way. But that can be really taxing. So I think that one of the things that I think is important is that I think in this climate, although it is very polarizing, there are a lot more people that are aware, and many of those people do not look like me, right? So I think it's finding those individuals who are going to stand next to me and say, like, you know, I want to learn more. I mean, even I'll take that, right? If they're like, I'm not coming from this underrepresented background, but I want to learn more, and I think that you'll find that those people are out there. So just kind of listening up for that, and also seeing who signs up. I will say in our diversity, you know, we have a fairly large diversity, called the IDEA Committee, which is has several different arms at Penn. And we really did make it a point to have that. And I'll give credit to Dr. Hamilton, who is sort of my mentor here at the University of Pennsylvania. We really tried to promote that it wasn't just for the underrepresented individuals, and you know, luckily, you know, a huge parts of our department showed up. So I think really thinking about those initiatives across the board. I do think it is challenging for, you know, people who do think that, you know, or like, one, that the system's not broken, right? Or that, you know, and I think those conversations can get challenging. What I try to do is really just try to focus on, you know, my set of knowledge, and then trying to, I don't think it's helpful to kind of get into these arguments with individuals who don't think that there's a problem. But as I mentioned, really thinking about those policies and how we change those. And if we, you know, looking at my last slide, if we take away the structural barriers, then we won't have to have all these other, you know, the affirmative actions and all other stuff, because it'll just be equitable. It'll just be fair. And I know that's a lofty goal, and we're far away from that right now, but it is, I think, something that we need to keep our eyes on, and need to really think about how we do this in the best possible way.
Douglas asks, do you have suggestions for junior faculty who want to develop academic careers in addressing health inequities and social determinants of health? What are potential mechanisms of support?
Yeah, so great question. I mean, you know, what I would say is that I'm aware of several programs. I believe the NIH has programs in which you can really learn how to do this well, and they'll support, you know, research in this area. And so I think but I do think it's a little bit of, you know, uncharted territory in some ways. And so I think having mentors in this area is really important, and then finding maybe programs that are going to support your efforts, because sometimes it's slow going. There's multiple factors that are the interplay, but I would really, you know, look at the NIH as a potential, you know, a potential landing space, and then talk to other individuals at the AN or even at your local institution that might be doing this type of work, to see kind of what their roadmap is. I really am a strong believer in mentorship, and so really finding an individual that can at least help you with some of the stumbling blocks as you try to figure out how to have a career. But it's very possible, and I think it's something to really, you know, it's very necessary.
Someone asked, our underrepresented in medicine faculty are getting burnt out from doing so much of the diversion, inclusion, and equity work. What suggestions do you have for helping your IM faculty feeling empowered to do some of this work? It says, they also noted, I like your suggestion for having them include an inequity piece when they teach. Yeah,
thank you. I do think that there is a diversity tax. I do think that a lot of underrepresented providers feel an obligation, because there's few of us, there, you know, the burden becomes much higher. I will say that we want allies, you know, I'll speak, you know, and so if you are somebody who is interested, I think, you know, approaching, you know, somebody, and, you know, and if they're doing diversity work, if there's a committee you can sign up for it, you know, be there as an ally, because I think it is going to take all of us stacking hands, as I mentioned. And so I think just show up and find out what they're doing, and don't be, I think, intimidated. I've had some of my colleagues kind of say, well, you know, I'm not from this group, or, you know, and I don't know how I can be of help. Like, that's okay, right? Because I think that intention is what, you know, your colleague is going to hear. And I think that, you know, putting your heads together, if you have ideas about how to address this space, it really means a lot. And it's going to take all of us. So I think, you know, the fact that you raise your hand and like want to sign up, like, I'm going to say thank you, because I do think we're all needed.
Well, no other questions from people. So if they have more questions, please feel free to put them in the Q&A section. But I do have a question. when you're trying to encourage underrepresented high school students and college students to get into the sciences, to get into medicine, what is your approach? How do you encourage them? How do you get them excited about, joining our field at the end of the day?
No, that's a great question. I mean, I think for me, I think a lot of it stems from self-efficacy, right? Like a lot of students have been told, like, you can't do this work, or why would you want to do that? Or it's such a long road, like all of these things that are sort of like, you don't belong in this space. And so I think it's the developing sort of interactive hands-on experiences, even seeing, individuals that are in healthcare, whether they're underrepresented or not, although I think it is helpful for them to see, individuals that look like them as well. But I don't want that to be a deterrent to actually having programs for high school students, middle school students who are going to think about pursuing a STEM career. But it's that development of just kind of their own personal self-efficacy, that what I put my mind to, I can do, and that science and math are for me, and that I am an asset. I really try to do an asset-based approach. You are an asset to this. Sorry, it's not, you're not like, oh, please, 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 like, please just take me, which, I mean, that is kind of the feeling, but you're really an asset in this space. And if you could look at yourself for the strength that you bring, I think that also gives you a sense of sort of pride, that you're pursuing this career. So I think that really looking at that development of self-efficacy and really assessing that, and with all of our pipeline programs, trying to get like a nice validated actually study of like how to assess that, right? When someone has self-efficacy. So I think that that's that. But I also think like you have to have the wow factor. Let's do like a dissection or whatever, something that's really hands-on. I think that clenches my students all the time when they just are like, wow, that was really neat. Whatever I just saw, and that I could do that in medicine. I think for some people, and we talked about this earlier, the concept of what neurology is, it can be a black box. And so I think that education of like what a neurologist is, and again, another plug for AAN, they have a really cool, website that's called What is a Neurologist, for medical students and the lay public. And if AAN, the annual meeting is in your city, they've traditionally done the Brain Health Fair, which is for the community. I don't know that they're doing that in the setting of COVID, but it's it's really for high school students, I think even middle school students who can come and kind of learn about neurology, and they have some fun interactive material for them to engage with. So, I think that, I think it's really that wow factor, and then that encouragement, and then mentorship. I mean, I think like having like those real conversations with someone who can help them navigate that space, I think is also really important, because I think that for underrepresented individuals, a lot of them don't have that mentorship. And so if you can provide that as well, that's going to be huge for these students.
All right, I don't see any more questions. Thank you so much, Dr. Lewis, for this amazing presentation, for your thoughtful answers to all of the questions, and just for all the work that you're doing. I mean, you really are making a difference really across the country, particularly in Philadelphia, where I trained as well. And, you really do amazing work. And I really hope that you continue bringing more and more amazing kids who would otherwise not come into medicine and into the sciences to join our fold and to make a difference and continue to make a difference going forward. So thank you so much for coming here today and talking to us, and for everything you do.
Thank you. Thank you. I want to wish everybody a happy, good weekend and happy holidays. And thank you again for attending. I appreciate it.